Good afternoon and welcome to today's IAC webinar, Cardiac Amyloidosis Interpretation Best Practices. My name is Kelly Baer and I am the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will monitor questions throughout the presentation and try to answer as many of them as possible during the Q&A period. Also on the left sidebar is the Resources tab. Click this tab for a link to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during this webinar, click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the ARRT Category A CE credit, you must be registered, logged into this webinar, then complete the survey. The survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. If you're viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. This webinar is a joint presentation of IAC and FASNC. And now I would like to introduce today's guest presenter, Dr. Scott Jerome. Dr. Jerome is Director of Ambulatory Services and Outreach of the Division of Cardiovascular Medicine at the University of Maryland School of Medicine and is an Assistant Professor at the University of Maryland School of Medicine. A board-certified cardiologist, Dr. Jerome specializes in general and nuclear cardiology as well as cardiac CT. He is a fellow of the American College of Cardiology, the American Society of Nuclear Cardiology, and the Society of Computed Tomography. Dr. Jerome also serves on multiple committees of the Society of Cardiovascular Computed Tomography and the American Society of Nuclear Cardiology. In addition, he is the immediate past president of the Intersocietal Accreditation Commission for Nuclear PET and is on the board of directors of the IAC. And we are happy to have him with us today. And with that said, I will now turn this webinar over to today's speaker, Dr. Scott Jerome. Doctor?
Well, thanks everybody for coming to this. It's hot and humid where we are, so inside is a better venue. First, disclosures. I actually have none. I wish I did. And our objectives today is going to be to understand some of the disease process of amyloid. I'm going to try to clarify some of the reading interpretation pathways, to understand the steps, missteps that we go through when we're interpreting these studies, and to understand some of the landmines, the false positives and false negatives that we experience. I want to finalize it with how to make a diagnosis and some reporting requirements. So the outline is going to be review the disease process, some red flags to look for, interpretations, and I'm going to walk us through some steps to interpret, diagnosis, and then report documentation. So let's start off. Why the new interest in amyloid? 5 years ago, no one spoke about amyloid. Well, it's an important cause of heart failure. About half of heart failure has a reduced ejection fraction. Half of heart failure has a preserved ejection fraction, normal heart function. And we've really been unable to treat these people effectively, and we really didn't have a great cause. But we're finding out that amyloid is a large etiology of this type of heart failure, about 15%. And it's frequently undiagnosed. So it's always been there. We just never looked at it. And it can have a very poor prognosis. So it's an important diagnosis to make. Diagnostic modalities have improved significantly over time. So it makes this easier to make diagnoses. And the diagnostic modalities continue to improve. So this is a moving target with this disease. And one of the most important things are that there's new treatment. We've got treatment for ATTR with tafamidis, And we've got 2 TTR silencing drug knockout drugs that are now developed and FDA approved and out on the market. So before we could diagnose it, couldn't treat it, so we didn't really look for it before. So what is amyloid? It's a disorder of misfolding proteins, and misfolded proteins deposit in organs and tissues. And they deposit in all the organs, all the tissues, including the heart. Now, I find this disease very confusing. There are multiple terms, multiple subtypes, multiple names, and it's easy to get kind of lost in the sauce with this thing. You know, you hear wild type and AL and transthyretin, light chain, senile, genetic, mutant, and it can be very confusing on how to do this. So I'm going to try to explain it in some simple terms so we're all on the same page when we use different words to describe the same thing. So amyloid, very top at the beginning, we're going to break this into 2 types of amyloid. On the right side of this, it's my right side of the screen, is light chain disease, or AL. It is a bone marrow disease. On the left side is ATTR, and this is a liver disease. And it breaks out into 2 types. The wild type, previously known as senile, so you'll hear both terms used frequently. And then there's the genetic or the mutant type. So these terms are equal, but it's easy to get confused. And to look at it a little closer, the AL standing for amyloid light chain, a way to remember it. Bone marrow, it puts out light chains that then can deposit in the heart. Can you see my pointer? I think you can. There it is. They deposit. The wild type or mutant type, transthyretin, ATTR, it's a tetramer is the protein. Tetramer breaks into 2, and then it breaks into each individual component. And these proteins then deposit in the heart. This depositing into the heart, now remember, it deposits into the valves, the atria, the entire heart, so all the heart structures. And it's a slow, gradual process. So cardiac amyloid, 2 major types, the liver origin, ATTR, transthyretin, and many other types of amyloid. So the senile wild type, age-related, and it's through a transport thyroid retinol protein. The genetic type is an autosomal dominant disease. The most common genetic is the VAL122, mostly seen in African Americans. But in reality, there are 120 or more mutations that we've identified so far. So this is a very complex disease. This is synthesized through the liver, and it seems to occur in ages greater than 50, although other types of amyloid occur in young people as well. Now, there's things called what I call red flags that's out there, and these are things to look for. And the first one is the neuromotor neuropathy. People who complain of weakness, difficulty walking, pain, tickling, a peripheral neuropathy. That overlaps with other peripheral neuropathies as well. Diabetes causes peripheral neuropathy, so put that in the back. Then we've got autonomic neuropathy. So people present with orthostatic hypotension. And again, there are a lot of causes for orthostatic hypotension. Then there's the ocular manifestations, kidney manifestations. Remember, these proteins are getting deposited in every tissue. We can get nephrotic syndrome. We can get proteinuria, renal failure. It can affect the brain with headaches, ataxia, things like that. On the right side, there's macroglossia. These proteins get deposited in the tongue. Interestingly, carpal tunnel, bilateral carpal tunnel, can present 10 years earlier than you start suspecting. That's one of the things that makes this a difficult diagnosis. We're going to go over it. And spinal stenosis. And most of these spinal stenosis, carpal tunnel, are things that we see every day, but we never really put it all together into one nice little package. So the cardiac red flags are heart failure with preserved ejection fraction. Again, that's about 50% of the heart failure that we see. Another thing is unexplained wall thickness on an echo of greater than 12 millimeters. When we think of echo and wall thickness, we think hypertension. We see what we call left ventricular hypertrophy very commonly. And those of us who read echoes every day, LVH, 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 we got to start thinking about causes of LVH. Is it manifested? The other thing is low voltage on EKG, and that occurs in about 56% of the time. You hear that, but it's only 56% of the time. So interestingly, when you're reading an echo or looking at a report and you got a wall thickness, you may not have the EKG there to put these 2 things together. The other thing is aortic stenosis. About 16% of the TAVR evaluations, thickened valves, have amyloid. And amyloid might be the cause of their aortic stenosis. Another thing we look at is normalization of blood pressure. We go, wow, we're really doing great. Your blood pressure is great, and we're taking you off a pill. You've done great, and then we take you off another pill. So we have to think, what changed? Why is this person's blood pressure normal now? It's kind of same thing with diabetes. If nothing has changed in the diabetic, they didn't lose weight, didn't change their diet, why are their blood sugars now normal? That could be renal function. Normalization of blood pressure could be amyloid as well. Atrial fibrillation, the most common arrhythmia we see. Boy, amyloid people certainly have atrial fibrillation. And then the big kicker is intolerance to heart failure medications. We start treating these people for their heart failure with preserved ejection fraction, and they're just not doing well with the drugs. So putting all these together makes it a little difficult. So what you need is you got to keep your antenna up. You got to have a high level of suspicion. So each red flag is in isolation, and they occur in different time periods. The carpal tunnel occurred 10 years ago, so you got to read through the orthopedic notes from 5 years ago. You got to look at the spinal stenosis. Are they orthostatic? Where's that EKG? You got to put them all together. And I'm using the Occam razor's term a little wrong, but it'd be nice to take all your symptoms and things and put it into one disease process. So we need to be looking at left ventricular hypertrophy and look at wall thicknesses greater than 1.2. And when we do this, think of all the things that left ventricular hypertrophy could be. The most common is hypertension. We see that all the time. Hypertrophic cardiomyopathy, aortic stenosis, an athletic heart, Fabry's disease, and of course, amyloid. So the patients are complicated. They have more than one of the above. They could have aortic stenosis and left ventricular hypertrophy and hypertension. So how do we narrow this in to amyloid? And that's one of our big challenges. So we need to differentiate the types of amyloid with some of the clinical differences. So the AL, the light chain, but frequently presents with sensory motor and peripheral neuropathy. Autonomic neuropathy, orthostatic hypotension, which we all see, especially now, people are coming in, they're a little dehydrated, their blood pressure is dropping. Is that amyloid or is it dehydration? Renal involvement, nephrotic syndrome. We've got to keep our antennae up and look for these things. With ATTR amyloid, it's usually white males who all of a sudden now present greater than age 60 with heart failure and preserved ejection fraction. African Americans with an ejection fraction, with heart failure, preserved ejection fraction, left ventricular hypertrophy without hypertension. How do I explain their wall thickness? Also a new diagnosis of hypertrophic cardiomyopathy, as well as a new diagnosis of low-flow aortic stenosis. Got to start thinking about this and putting it all together as one. Now, the diagnosis is made with multimodalities. It's just not one test. So we got to have the clinical suspicion. You see LVH or an echo, or a patient presents to the hospital or your office or wherever you are with heart failure and preserved ejection fraction. And some of the modalities we use are nuclear PYP, which we're going to focus on today, echo, MR, blood, urine, as well as biopsies. We really need to use all of our tools to make this diagnosis. So now let's switch over to the paraphosphate scanning, the PYP. It's a bone avid tracer. And we used it in the 80s for myocardial infarction imaging, kind of fell off the map. No one heard of it. You know, you ask a fellow 5 years ago, what's PYP? They have no clue. So it's a calcium-dependent P component, binds the amyloid fibers together. The PYP then binds via the calcium mechanism to the calcium-dependent P component. So that's how the PYP binds to the amyloid fiber, and that's why we can see it. So we need to exclude AL. We need to exclude that bone marrow disease because positive PYPs 20% of the time can be AL amyloid. Now, in order to exclude AL amyloid, and I'm going to repeat things a couple times over and over again because I have major points I want to drive home. You gotta check these three things at least. You gotta check the serum-free light chains, the kappa and the lambda and the ratios. You gotta check the serum immunofixation and urine immunofixation. And it's not a serum protein electrophoresis that we order. Before it was, order serum protein. Now you gotta get these three tests and you gotta exclude AL amyloid. AL amyloid is a different disease. They need referral to a hematologist oncologist. It's a bone marrow biopsy, which may make the diagnosis. And the treatment is very different. It's chemotherapy. It's not the things that we're going to talk about, tafamidis and some other treatments. So it's a very different disease, although it comes under the name amyloid. It's still protein depositions. But we really got to differentiate these two. So how good is this test, this PYP test for amyloid? So grade 2, specificity 100%, sensitivity 72%. And that's from internationally renowned centers, amyloid centers. And then we started doing this out in the community. And I would get feedback from other people saying, the test isn't as good as they say it is. The test isn't as, what's going on here? Are we making mistakes? Are we doing it wrong? So not so fast. So do these numbers hold up in the community practice? Well, they probably don't. Just like everything else that's new, the Center of Excellence does it. It's well controlled. It's looked at by 4 people before the report goes out. It's very carefully controlled. All of a sudden, things start happening in the community, and everybody's practicing a little different. Standards are a little different. Protocols are different. Levels of experience are different. So the numbers change. So what we're having is some misinterpretations. And the more studies we do, the more lessons we need to learn. And this actually stimulated a very nice paper in JACC this past June, so it's right off the press, to talk about some of the misinterpretations, why we make misinterpretations, why we're making wrong diagnoses. And I think when I started into PYP, there was confusion on how to interpret these studies. You look at the guidelines and you go, what do I do? How does this happen? So I'm going to try to clarify that and make it simple. So the nuclear diagnostic workup, what is positive for ATTR? Basically, the presence of a grade 2 or greater. And I make this important, and the absence of the monoclonal antibodies by serum-free light chain and immunofixation. You got to have both. If the blood and urine are abnormal, no matter what the imaging is, they need referral to hematology oncology. Remember, AL can have a positive PYP scan. Now, we've got great guidance on this. FASNC website is filled. They've got a whole section. They've got practice points. They've got the new consensus statement for multimodality imaging for cardiac amyloid. It was just a year old, and there's blogs, there's webinars, there's archives. They've got a whole section off to the right on how to walk through this. So there are a ton of resources on what we need to help us be better imagers on this. So, interpretation confusion. The first thing is the grading. Do we do grading? Do we do heart contralateral lung? Out of the 3 methods, which do I use? Do I do visual interpretation? Do I do heart contralateral lung ratio? What's the story? What's the story with Spect? Where does this fit into all this? And then you read the guidelines and you go, it's 1 hour and it's 3 hours. Do I do the 1 hour? Do I do the 3, or do I do both? So I found this confusing, unsure, unclear, perplexing, and kind of lost in the sauce. So to me, I break it up into 3 parts to interpreting these studies. First is the visual interpretation, otherwise known as the semi-quantitative grades. Again, different names. Semi-quantitative grades, visual interpretation, the same thing. The next is Spec, and if you've got FSCCT is preferred. You got to do that. And then third is this heart to contralateral lung, and that's the quantitative part. So now we've got a bunch of names. We've got semi-quantitative, quantitative, visual inspection, heart to contralateral lung, Spec, all these terms being thrown out there. I want to make it really simple, 1, 2, and 3. And let's kind of go through this pathway a little bit. So step 1, which I like to do, is the semi-quantitative, the grades. Do this first. Look for diffuse uptake versus focal uptake in the heart. Diffuse uptake, you want to think amyloid. Focal uptake, it might have been a previous myocardial infarction or other etiologies for focal uptake. That's step number one. So again, multiple names for this: visual interpretation, a grading scheme, and semi-quantitative. Confusing, all three terms mean exactly the same thing. So this, the visual interpretation, is your estimate of tracer in the heart compared to the ribs. That's all this is. It's a little difficult. When we started doing this, and actually I had someone say to me recently, oh, I hear those scans are really easy to read. Let me tell you, they're not. The more we do, the tougher they get. So grade 0 is no heart uptake compared to the ribs. And we consider that negative for ATTR amyloid. Grade 1, the heart uptake is less than the ribs. And that's an equivocal study. And we all hate equivocal studies. We want to either be negative or we want to be positive. Grade 2, heart uptake equal to the ribs. And that's strongly suggestive of amyloid. And then we've got grade 3, heart uptake greater than the ribs. And that's positive for amyloid. Again, we always need to exclude AL amyloid as part of this. Now, how do we interpret this? And I'm sure many of you have seen this image before. It's on the website of FASNC. So here is grade 0, and you can see that there's really no uptake. And then if you'll go over to grade 3, all you see is heart compared to the ribs. This one's really easy to see, this one. Now, interesting, you want to look here, and can you see that ventricular cavity? Is there no blood pool? I'm going to spend a little bit of time on blood pool. There's no blood pool. It's diffuse uptake of tracer throughout the myocardium, and that's what we like to see. Then we've got our grade 1 and grade 2. Grade 2, the heart is equal to the ribs, and this is suggestive. Again, the blood pool is clear here. It's diffuse uptake, and we're looking at the ribs and the heart. And then we've got our grade 1, where the heart is less than the ribs. All right. The higher the myocardial uptake, the worse the prognosis. So that grade 3 has a worse prognosis than a grade 2 or grade 3. Remember, if it's taking up PYP, there's more amyloid protein in that myocardium. Full body scans. Now, this one's pretty obvious too, but many of us don't do full body scans. I know in my scanner, it's more of a cardiac scanner, so I don't get to see this. But again, grade 3 is pretty easy to see. You can't miss that one. Here you see no heart. It's these two that are always in the middle and always tough to see. But this one's pretty easy. You can see the heart greater than the ribs here. And right here with our grade 1, the heart is less than the ribs. And you want to look at flat ribs. You don't want to look at ribs on edge or where there's more bone coming up. You want to make sure you compare it to flat ribs. All right, step 2, you need the Spect. You gotta rule out blood pool, and you gotta look for diffuse versus focal uptake. Now, I'm gonna go over blood pool. Many of you probably know this, but to go over it one more time, I don't think hurts. And everybody will then be on the same page when we talk about blood pool. So, believe it or not, this is a picture of the heart. Left ventricle, inner septum, and the ventricular cavity. When we zoom in on this cavity right here, and we do a Spect, we see this nice image, and over here, we don't see any heart uptake. Now, what we're looking through when we look through here, we look through this wall, and we look through the posterior wall here. We're just looking through the walls. Remember, this area is clear. There's no blood in there. Blood carries tracer. If all of a sudden now, we put blood with tracer, we are now looking through the entire length and depth. So our tracer number goes up, and now you can see the heart. So this is blood. This is the definition of blood pool. Many of you know it, but I just thought reviewing it for a second or two just reinforces. Forgot about that little arrow. Okay. Now, step 3. the heart to contralateral lung ratios. We all want a number. Everybody wants a number. Above this, it's positive. We want a positive, we want a negative. So many times early on, people were just doing heart to contralateral lung ratios, coming up with a number and saying positive or negative. They were skipping the grading system. As time has evolved, research, experience, we've learned to mature our interpretations. This is the third step now, because there's a lot of places to make errors in this heart to contralateral lung interpretation. It's easy. We want a number. Oh, above whatever, it's positive. It's just not that simple. Just like when we do a MUGA scan, the computer spits out a number and we say, oh, there it is. But we all know we can manipulate those numbers a little way. All right. So quantitative heart to contralateral lung. It's the region of interest on the heart compared to the contralateral lung, and you look at the ratios. Now, 1.5 strongly suggestive of disease at 1 hour. Now, over time, the tracer dissipates. So if you're doing a 3-hour scan, a positive scan is 1.3 or greater. That also is suggestive of a positive scan. And then we get what we all love is that equivocal. What do we do with this equivocal? And I'm going to try to straighten that out a little bit, see if we can hone in our diagnoses a little better. So this is an important fact here. The 3-hour, 1.3, you can kind of remember 3-hour, 0.3, and the 1.5 at 1 hour. Now, many of you have seen this. This is a pretty popular image that we all see, again, showing region of interest over the heart, region of interest over the contralateral lung. This you can kind of tell even without. This was positive. The heart to contra lung is 2. There's no question about this one. Here's another image, pretty popular out there that we see. Here you can see they are equal. You don't have a positive. Here, the ratio is clearly different. And again, we see it here even without the contralateral lung. So if we just do the grading system, we can say, boy, this one is a grade 3. We can tell that. This one we can say there's no heart. So the heart to contralateral lung kind of helps confirm what we're already seeing. And remember, in my little way of interpreting this, this is the third step to do. This is the last thing that I want us to do. Now, this is one from my lab that I pulled. And interesting, this is a 3-hour study. And what I wanted to point out here, we have our region of interest in different places. If we put it right here, we were going to get maybe liver, get some rib involved. It's okay to move them where they're different. Now, of interest, this is 1.3 at 3 hours. This was a positive scan. Again, just looking at it, though, we thought the heart was greater than the ribs and called it positive with our grading system, and then our heart contralateral lung ratio helped confirm it. Remember, this is 3 hours and 1.3 is positive. Basic scanner, pretty good images, pretty good result. So ATTR diagnosis cannot be made solely on the heart to contralateral lung ratio. I just really want to make that clear. That's what people, when this first came out, a lot of local cardiologists said, oh, we'll just do this, it's easy, and we spit out a number, and there are the results. So remember the normals here. 1.5 at 1 hour, 1.3 at 3 hours. Use this ratio to help confirm your grades 2 and 3. It's a confirmatory for grades 2 and 3. Use it for the equivocal, grade 1, grade 2. Help it as the tiebreaker. We're trying not to give equivocal tests. We really want to give people the answer they're looking for. So use that third. That's not the first thing we use. What makes a positive test? Positive for ATTR, positive PYP is a grade 2 or 3. You then need that Spect evaluation. Make sure there's no blood pool. Make sure there's diffuse uptake, no focal uptake. Make sure you've got negative free light chains. Make sure that the urine and serum are negative as well. To make this diagnosis, remember, we use all our tools. Use the clinical scenario. What's the patient like? Use the echo results. Use the MR results. And then use this heart to contralateral lung to help confirm your results. Once you make a positive diagnosis of ATTR, you got to do genetics. Remember, ATTR breaks down into that wild type and then the mutant or genetic type. So everybody who's positive should get a genetic test because that's going to be passed on to families, and that changes the way we do things and how we look at the patient. Really important. We don't talk about it enough. It's easy. It's a saliva sample. Need it all. Now, can you differentiate ATTR and AL by a PYP? So if we think about this, 50% of AL have cardiac involvement. Makes sense. The protein's floating around the body. It's going to get stuck in the heart. Greater than 20% of AL have a positive PYP study or have PYP uptake. And it's usually low-level uptake. It's a grade 1 or grade 2, but not always. Right? We can't mess this up. We can't mess this diagnosis up. We got to get it right because it matters on the treatment, the prognosis. Ramifications are very different. So in all patients, don't forget the blood and the urine. Really important. And I see as I get phone calls from other sites for a consult or some assistance, oh, what did the blood show? Oh, we didn't do the blood. All right. So let's go over some misinterpretations and common causes of this. So remember pretest probability. In the original studies, they were from amyloid centers. So they're amyloid centers. All those people have amyloid. Their tests are going to overestimate the accuracy, right? Our general population is not a pre-selected population. So the test that said 100% may not be 100%. The second thing that we do is we miss blood pool, and that's secondary to lack of Spect imaging. So we need to really concentrate on the Spect. And if we've got Spect CT, that's really great, but many of us don't have Spect CT. The failure to rule out AL is an important cause for misdiagnosis. And then we've got technical factors. Intensity of adjacent ribs, which you get in your region of interest. Patient rotation. The other thing is renal dysfunction. Tracers not excreted as quickly. Area of interest errors, where we're placing that. And then, depending on a number, is not the way to do this. So these were all the reasons, not all, but many of the reasons why we're missing our diagnosis on this. So let's go over some false negatives. When do we miss this diagnosis? So early disease, we can miss this. Remember, the first day you get this disease, you've got one piece of protein. PYP is not going to attack that one piece, and you're not going to be able to identify that one piece of protein. It's on a continuum. And depending on where you get that patient on a continuum tells you how positive your test is going to be. Remember, if we look back at MPI studies, you have somebody who may have a 70% stenosis and they're a little positive. You got somebody with a 99% stenosis, they're going to be really positive. So this is a disease going on for years, slowly accumulating protein. It's going to take us a while to figure out where in the disease process we're making this. The other type is there are rare types of amyloid. And I throw these other genetic forms up there that are out there. Remember, there are over 120 different genetic forms. These don't take up tracer as much as ATTR, the kind that we're looking for. So 120, they take up a little bit of tracer, so we can easily miss a diagnosis having a false negative. A large previous myocardial infarction may not take up tracer, so the total tracer in the heart is down, and it doesn't meet diagnostic criteria. But remember, that tissue is dead. It may not be taking up tracer. You got to look at that Spect for focal uptake versus diffuse uptake. Now, remember, a person can have a heart attack 10 years earlier and then develop amyloid. So you can have two things going on at once. And then, of course, we've got technical, poor tag, things like that. All right, so let's take a look at this one. This test was done for high clinical suspicion. The doc said, and this is taken from article Hannah. Hannah had a great article just out in JACC. I refer anybody to it. High clinical suspicion. They did a PYP study. PYP comes back. They diagnosed as grade 1, heart, lung, contralateral lung, 1.2. They're calling this a negative study. Here they look. Here's the Spect scan. And lo and behold, the teaching point was clinical suspicion was high. PYP was negative. It was positive for one of these rare types of amyloid. So if you think you've got amyloid, negative P, and your clinical suspicion is such, go for a biopsy. We do this with cardiology all the time. Patient walks on a treadmill, they may have balanced ischemia, but our clinical suspicion is pretty good because every time he walks up a flight of steps, he gets typical angina. So we do not necessarily believe the test, and we still cath that patient. Same thing here. Our clinical suspicion is really high. Go with your gut. See if you can figure it out despite what the test says. This was a rare type of amyloid that they presented. They did an excellent job presenting this case. Let's go into false positive tests now. Cardiotoxicity, hydrochloroquine. Don't take it for COVID. Then our region of interest. Do we have overlapping structures? Do we have ribs in the way? Myocardial infarctions, regionality again versus diffuse. Pericardial, chemotherapy, myocardial contusions, all can cause false positives. Blood pool, again, that's addressed by your Spect and your FSCCT. So let's look at this scan. Again, this is taken from Hannah's article. And what do we think this is here? If we're looking at this, we think that this is a positive PYP. They think that the heart here is greater than the ribs, and they're calling this positive. They then do a SPECT-CT, and lo and behold, big blood pool. Myocardium, no real uptake. So this SPECT-CT is really important, and this really helped make the diagnosis of this. So we're seeing blood pool that's accounting for the high counts here. So the lesson to be learned is look at the spec. All right, here's another example. This was taken out of state-of-the-art imaging. This was in JNC. Another nice example. Just to show the example, when we're looking at this region of interest, we're counting all the counts. We've got a rib fracture here. That goes into the count number. That changes our region of interest. So by heart to contralateral lung, it's greater than 1.5. Oh, he's got it. Maybe not. There's a rib fracture. And count that when you're making your reports. All right, let's look at this other one here. So we look at this study right here, and boy, all you see is heart. You can't really see ribs. This is a grade 3. This is a no-brainer. This is pretty easy. The heart to contralateral lung ratio is 1.8. Diagnosis of ATTR, wild type, slam dunk, right? But they did the blood, and look what they found. They found the kappa and the lambda ratio to be different, okay? So this person's got more than just ATTR, and the teaching point is always do your blood and urine tests. Really critically important here. All right, the next confusing thing I found is 1 hour and 3 hour, 3 hour only, 1 hour only. How do I do this study if I'm just starting out how to do this? So if we kind of break it down, the 1 hour is a visual assessment. It's more sensitive, less specific, okay? The con to doing the 1 hour is you could have blood pool accumulation, especially if you've got renal failure, maybe a low ejection fraction, you may not clear that blood pool out. So that's the positive and the negative of the 1 hour study. The 3 hour study, longer time for bone accumulation, less chance of blood pool because you got an extra 2 hours to get this out. The better specificity, less sensitivity. Remember, they're always inverse, specificity and sensitivity. So which one do we use? Do we need both? Now, Sperry in May came out with a very nice article in JNC, and they looked at imaging time. I think they had the same question. And what they found was the imaging time did not affect the interpretation of the study, whether it was a 1 or 3 hours. They found that there was less blood pooling at 3 hours, but they used SPECT-CT for myocardial localization to help make the diagnosis. They had SPECT-CT. Their conclusion was that people should be doing 1 hour, but they found no difference between the 1 and 3 hour. when you interpret this, or the way I interpret it, we can talk to the author clearly, but I think both are okay then. There's no big difference between the 1 and the 3. Do we need them both? All right, so the pros and cons of the 1 and the 3 hour. If you use the 3 hour imaging, it's more reassured that the blood pool is gone. You're just waiting a longer period of time. The blood pool is going to clear out. So if you don't have Spect CT, or you're having some trouble imaging that, you may want to wait and just do a 3 hour study. If you use the 1 hour, it may help your lab put through. You need to make sure that blood pool is clear. You may need to bring them back. If you do 1 hour and you see blood pool, you may have to bring them back at 3 hours. So now you're bringing the patient back twice. Depends on how your lab works. If you've got a Spect CT, you get better visualization of the blood pool. So you always need to do Spect. My 2 cents, what works for your lab. I changed our lab. We started off 1. We've gone through, over the year, 2 years, we've gone through a bunch of changes in how we're doing this. For our workflow, we decided just to go to 1 scan at 3 hours. Some places, it may work better to do the 1 hour scan. Remember, there's no difference as long as you exclude blood pool and as long as you do Spect CT to evaluate this. All right, let's move on to a little bit of reporting. So reporting requirements. All reports need to be standardized. We really need to, as we do standard protocols, procedures, quality, reporting needs to be standardized. So we're all talking the same language. So a report that I do in my lab gets sent to California or some other location. We're all talking the same language. It basically needs demographics, the name, the age, sex, date of the study. These are required elements. The method, image quality, visual scan interpretation, semi-quantitative interpretation, relationship to ribs. These are required things that we need to put in. And then you need to do Spec, and you need to do Spec on every study. You really do. All right. Reporting optimal or recommended. Heart to contralateral lung is optional. It's recommended for positive scans. Remember, it helps confirm the positivity. Whole body imaging, a lot of us can't do it. That's optional. And then if you've got CT for attenuation, that's recommended as well. All right, in your conclusion, and this is to me is the most important part, overall interpretation, not suggestive of ATTR. This is a grade 0. Strongly suggestive of ATTR, grade 2 or grade 3. Unequivocal for ATTR, grade 1. Use your heart to contralateral lung ratios to help confirm. Interpret in the context of all your data. So we need that MR, we need the echo, we need the blood work. And I look at this just like we do an MPI report now. We look at everything. I do a stress test report. I look at the treadmill time. I look at the symptoms. I look at the EKG findings. I look at the pretest probability. I look at old images. I look at old studies. We may not have all this when we're doing PYP studies. In my stress lab, I've got all this data. But we really want to make a clear conclusion and risk assessment for this patient. Here's the problem. When we're reading a PYP study, we may not have access to the echo, the MR, the urine, the blood. There's an order set. Somebody just ordered everything. So you look at the image gets ordered first. You don't have this other data in front of you to help confirm your diagnosis. It may be coming from another medical system to help confirm your diagnosis. So you don't have all this stuff to help you. You don't have the treadmill time as an analogy to help you. So what you need to put in your reporting, and this is really important, you need a statement addressing the appropriate lab testing to rule out AL, and it must be performed for the accurate interpretation. If you've got this data, when you're reading, you can put it into your report. If you do not have it, and I know in our place, patient will get done for a scan, and you read the scan and you say, well, where's the other labs? The patient didn't go yet. They had work, or the lab is delayed. So it's tough to make a full interpretation. If you've got the data, make the full interpretation. an accurate interpretation. If you don't put something in there, that AL has to be ruled out before you can make an accurate interpretation. And now, conclusion in our Twitter world, I like to put a few big points. If you're going to remember anything, these are 6 things I think we need to remember. Semi-quantitative, Spec. We can't exclude AL without further testing. Heart to contralateral lung to help confirm your diagnosis. Look at all the data, and if it's positive, do genetics. And that's the formal presentation, and I'm happy to answer any questions.
Okay, thank you very much. And at this time, we will begin the Q&A session. From IAC, I'd like to introduce Maria Costello, IAC Director of Accreditation for Nuclear PET. She'll be assisting us with the Q&A session today. Maria, would you like to start us off?
Sure. Thank you, Kelly. So, Dr. Jerome, we had quite a few questions about the timing of the imaging, and I know you reviewed it extensively, but I'm just going to try and summarize all the questions, and maybe you can just repeat a little bit to make sure that everybody understands this. Do you recommend doing both 1 hour and 3 hour imaging, or is 3 hours enough? I'm going to do this as a multi-part question, so do you want to answer that part first and then I can go on, or do you want me to ask all 3?
Yeah, let me see if I can answer that one. I think Sperry's article really said there's really no difference between the 1 and the 3 hour. What works best in your lab. So I think that if you do 1 hour, you've got Spec and Spec CT, you can clear blood pool, you can tell whether it's diffuse, you can just get away with a 1 hour if you're confident in that. If you're not, you can just do a 3 hour where your blood pool chances are less. And then the only time you have to do both is if you're 1 hour, you still have blood pool, then you got to bring them back for the 3 hour. So again, what works best in your lab? If you've got great Spec CT, then I think you're very comfortable with just a 1 hour study. Again, if you don't have Spec CT or just working through your lab's put through, you may just want to do a 1-3 hour study because then you know you don't have to bring them back again.
Okay, and so then do you need Spect if the planar scan is normal?
No. It's only for those false positives, right? You want to make sure that the positive is not blood pool, right?
Okay, so
but you should always look at Spec because you want to make sure there's nothing else going on. You should always look at Spec. It should be part of the routine protocol.
Okay. So that kind of sums up, I think, most of those questions. Now, can this test be done on a cardiac specific camera, or is a whole body camera preferred?
You can do it with cardiac specific.
All right. And then there's a few questions about PET tracers. And some question, is PET better for the diagnosis, and does it follow the same protocol? Or can you comment on the utility of PET tracers to directly target the amyloid proteins?
Yeah. So this is an evolving science. So we started off with our old faithful 30-year-old PYP. PET is a player in this game. Absolutely. PET is evolving. This is a disease and a diagnosis that 6 months from now, if I gave the same lecture and if it got broadened out to using PET imaging, it's going to be different. And then a year from now, it's going to be different. There's more and more PET data coming out. At this point in time, I'm not sure you can tell which is better right now. There's not enough data, at least in my mind. I think PET is extremely promising and may be the way of the future. But again, there are more Spec cameras out there than there are PET cameras out there, so I think we need to adapt to both ways of doing this. But PET is moving rapidly with tracers, absolutely.
Okay. You stated that about 15% of heart failure cases are due to amyloid disease. What do they estimate the prevalence of amyloid is in the population?
It's still considered a rare disease. So the whole population, it's still rare because we're not looking for it as much as the guy who does the carpal tunnel, he's not sending those carpal tunnel specimens off for biopsy to find out. So there's a lot of people that are undiagnosed with amyloid. They have orthostasis, and we call them Pott's disease, or we call them something else. I think there's a lot of misdiagnosis. I think amyloid is much more prevalent than we think. We're looking at our heart failure population. So 15% of that heart failure preserved ejection fraction. So we're looking at a specific population. For the general population, it's hard to tell. It's still considered a rare disease, but I don't think we look for it enough.
Okay. Would a genetic test alone rule out cardiac amyloidosis? If it's just an easy saliva test, why not just do that?
So the genetic test only rules out about 3% of this. So the ATTR that are positive, there's the wild type, and then there's the genetic type, right? And it's usually, at least the most common, the 122, is genetic. It's about 3 to 4% of that population. So once you get positive, it's only about 3% that are going to genetically test positive on this. Now, out of all the testing, only 3%. So you can't just go with genetic testing. It's a very small population, but it's really important for downstream. Do we need to look at family and things like that?
Okay. Is there any advantage of doing whole body imaging?
I don't think there's an advantage of doing whole body imaging. I mean, the pictures look nice, but I don't. From a diagnostic standpoint, I don't think there's an advantage. I think you can do it on a cardiac scanner with very good images and great diagnostic accuracy.
Okay. How do you exclude blood pool without the use of CT? Is that by using Spect?
Purely Spect. Yeah. Not everybody's got CT, so you got to do Spect. And I struggle with it. We still struggle with it, especially if the heart doesn't take up a lot of tracer. It's hard to identify it on a regular spec and to look for blood pool. Once the heart is taken up, then you can do a protocol where you're doing an MPI protocol, then you can see the heart pretty easily, and then you can exclude it, that's the most important part, right? If you're seeing the heart, you want to make sure that it's not blood pool as the reason you're seeing the heart. So you can just use regular spec on that. So absolutely, just use regular spec. If you got CT, you can really help for diffuse and focal, which just makes the images a lot easier to read.
Okay. Do you use strain as a gatekeeper for PYP?
As a gatekeeper, I don't know whether I use it as a gatekeeper. I use strain a lot. What we're beginning to do, at least in my lab, anybody with significant LVH, we're doing strain pattern. And for the strain pattern, for people who don't know, you get what they call the cherry on top. The apex is red and preserved where the base of the heart is not. And that's part of that confirmatory. So I see LVH, I got a cherry on top strain pattern. I've got a PYP positive. I keep adding these things along. Just because the strain is negative will not prevent me from doing a PYP study. Remember, because you're in that continuum, right? Only when the people really have pretty advanced disease do you see that strain pattern. So within that continuum, I don't, because I have a negative strain, that doesn't exclude me from doing PYP.
Okay, and I know once again that we discussed the 1 hour, 3 hour planar Spect a few times, but it seems to be an important concept. So, and we did get a lot of questions, and we are continuing to get more questions in about it. So I'll have you repeat again. What benefits do you see with doing both the 1 hour planar and the 3 hour Spect, and some cons?
The advantage of the 1 hour, okay, you get it done in 1 hour. Okay, it's a very sensitive test. It's a little less specific. The cons of the 1 hour, you can still have blood pool accumulation. You wait for 3 hours, that blood pool hopefully is going to clear. Especially if you only have Spec and not CT, you may want to wait to make just more reassurance that that blood pool is clear. You have with the 3 hour, longer time for time for the bone to accumulate tracer. You get better specificity with 3 hour and less sensitivity with 3 hour. Does that seem to answer the question?
I think so.
Yeah, and in my lab, I went And as Sperry's article said, they're both equal as far as your diagnostic accuracy. So what fits in your lab?
Okay, and can you please explain the kappa lambda ratio once again?
Right, so these are light chains. There's a kappa chain and a lambda chain, and they should be in a specific ratio. The ratio is normally, every lab's a little different. With us, it's 1.6 or less, the ratio. If you've got high levels of these, then you're looking at a bone marrow problem. And when we talk about bone marrow problems, we're talking about, this kind of goes along with the MUGUS and the multiple myeloma that we deal with. So it's the bone marrow putting out these light chains. Now the kappa, it should be 1. Kappa and lambda should be close to 1. So circulating light chains are partially cleared by the kidney. And as the glomerular filtration rate decreases, disproportional raise in your kappa light chains may occur. So kidney function is important. The lambda light chain predominant is never a normal finding. So if you get lambda free light chain prominence, that's never a normal finding.
Okay. How long does your lab scan each patient for? Do you use time or counts?
I think we're using counts.
Okay. A recent PYP study showed significant liver and spleen uptake at 1 hour. Is this a significant finding on this type of study?
That's a really good question. I think it should be looked into. Yeah. I definitely think it should be looked into. Remember, the accumulation of the proteins can accumulate into all organs.
Okay. With the cardiac offices that have cardiac cameras that can only rotate 180 degrees for Spect, is that acceptable or only planar images? And I think you covered this one a few times too.
Yep, I did. Exactly.
All right.
Yeah.
Okay, so is this the sequence for diagnosis? After enough clinical data suggesting, do blood and urine tests first, free chain, and immunofixation? If negative, do PYP scan?
No.
Positive?
They go together. You got to do your PYP and your blood and urine. They both have to be simultaneous. Yeah. Okay. You need both tests to make the diagnosis because you've got to differentiate AL, because AL will accumulate tracer in the heart versus ATTR. So there's blood help exclude or make that diagnosis. So you could have a grade 1 or a grade 2. You don't know whether it's ATTR or AL. The blood and urine will make that differentiation.
Okay. And I think we have time for one last question. Is a lateral image necessary or does the anterior suffice? Yeah,
I think if you got a good anterior, I think you're good. It'd be great to get lateral. We do lateral, but I think you can get away with, if you got to get away, you can get away with just an anterior.
Okay, and maybe one final one. In your lab, if you have a qualitative is 1 and your HCl ratio is less than 1.5, do you call that study equivocal and there's no CT there is no CT available?
Yeah, I would call that equivocal, but of course I'd make sure, because remember, a grade 1 can be AL. So they got to have the blood and urine to make sure I don't have AL.
Okay, and that's all we have time for today. Thank you, Dr. Jerome.
Thank you.
Okay, thanks again, everyone. Thank you, Maria, and a very special thank you to Dr. Jerome for this presentation today. Please feel free to contact IAC with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of this live session and also be available from the IAC webinar portal for 3 business days. On the left side of the My Account page, you'll click on Webinars. Look for the title of this session, Cardiac Amyloidosis Interpretation Best Practices. Beneath this title, you will click Review Event. On the left, select the Evaluation tab, then click Take Evaluation to complete the survey. Your certificate can then be accessed and printed from the very next screen and anytime thereafter through the CE transcript section on the My Account page. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you for joining us today and appreciate your participation.